Okay, good afternoon, everyone. So it's the final session of this lovely 3 days conference. And this is a session that will be talking about some ethical challenges in critical care. Our next speaker is Prof. George Ozinger. He's a chair of the Department of Critical Care at Cleveland Clinic London with a vast experience in critical care for over 24 or 5 years now. I'm not going to get more into the bio. The floor is yours. Otherwise, I'm going to take 2 or 3 minutes of your time here.
Please don't. Thank you so much, and welcome to the last session of a wonderful conference. I've sort of realized, really thinking about the topic, that this is quite controversial, and from the way I practice medicine, potentially quite different to how medicine is practiced here, and indeed in other parts of the world. So you've got a few definitions here. I don't think I need to read through them in detail, but just to kind of explain a little bit what futility, and I don't necessarily like the terminology very much, but if we are not able to make meaningful impact on the quality of life, the clinical condition, or the survival of a patient, we would sometimes say that this is futile care. So the key considerations, and I will elaborate on that in the next few slides, are prognosis, understandably. From a transplant perspective, which patient would indeed benefit from a transplant, which is a very costly intervention, and obviously involves not only the money, but also donation of an organ. And what are our primary treatment goals? Is it all about quantity, length of life versus quality? Physiological futility, I've sort of learned over the last few decades, and I've been practicing ICU now for 30 years, is a moving target. And again, you will see examples of that later on. Quality of life is, I guess, something which is really of primary importance, and we all know that ICU in general, and especially with very complex patients, is often associated with very poor long-term quality of life. And we've got very little understanding of long-term outcomes. We are very good in assessing survival, ICU survival, hospital survival, but we are very poor in actually looking at how patients fare 6 months, 1 year down the line. And that's especially important in relation to functional independence, mobility, and that's not the same for everybody or for everyone. So, there are a few important pointers here to make. Patient autonomy. This is something which I guess within the Western world is quite important. But I've also understand to learn and working a lot with patients nowadays in a different healthcare setting, which is predominantly private, and where we got quite a lot of international patients, that it's not only the patients, but it's often also the families, and the families demanding certain things. And often, unfortunately, in the ICU, understandably, where patients are not able to give consent, we are relying on surrogate assent and family assent, so it's often more the demands of the family rather than the demands of the patients. Beneficence, and that kind of assumes that we know best, and I'm not entirely sure if that's always the case. Not doing harm, non-maleficence, well, that's quite subjective. What somebody may perceive as being a harmful, inappropriate intervention, somebody else may see as being perfectly reasonable. And then we've got the element of justice, which especially in relation to limited resources, is probably very, very important, and that's certainly the case for transplantation medicine. So I guess that's part of the topic of this talk is, how do we assess prognosis? And there's lots of different scoring systems, as you can see them mentioned up there, which are particularly or less so useful within the realms of liver disease. We should definitely, and I think that's good practice, define and clarify what our treatment goals are. And yes, ultimately it's up upon us to decide what is best in that sense. And usually, obviously, from a medical perspective, it's not only prolonging life, but prolonging a good quality of life. I've already mentioned this, but what is obviously of utmost importance is engage with the patient in terms of what they want. And often, unfortunately, as I said, in that sense, it is the relatives. So the patient's values are frequently not known. And the final decision in terms of whether or not to continue or withhold further treatment, that's often a quite tricky one. And the longer I practice medicine, the less easy it becomes. So we've already talked about certain areas of practice where demand outstrips supply. There is certainly also, I would say, a societal and human cost of inappropriate support. And for us as healthcare professionals, we are often quite worried about an undignifying death. I always say, especially to my nursing colleagues, it's often easy for the doctors. We do a round, we'll see the patient for not split seconds, but moments in the day, whereas the bedside nurse is always there, 24 hours a day. And often it is the nurses who come to us and say they really find the whole thing non-dignifying. And then there is the cost of the survivors, delirium, long-term effects on survival, cognitive effects, and as I've already mentioned, the functional aspects, mobility, independence. From a healthcare evaluation and value of healthcare perspective, you've probably also heard of QALYs, quality adjusted life years, which look at disease burden, a composite of quantity and quality of life lived. And certainly, again, in the UK or in the US, that being also associated with how much money it costs and how much value it provides to society. So 1 year in perfect health. So financial aspects certainly come into play. If you were at a talk yesterday, I talked about acute and chronic liver failure, because mostly nowadays when we talk about decompensated liver disease in the ICU, we've got two entities to deal with. It's acute and chronic liver failure versus acute liver failure. It's a bit of a complex graph, but in the past we've talked about decompensated liver disease, but what we've understood, that's the red graph, so that would be kind of a sort of prolonged process whereby the liver may start to cause problems, decompensation with ascites, encephalopathy, and often patients are relatively stable for years, with a 5 to 10% per year incidence of decompensation and probably survival rate of about 50% by 10 years. But then obviously we're much more familiar with the ACLF, acute and chronic liver failure concept nowadays, so a distinct clinical entity where patients, due to a decompensation event, usually infection or sometimes bleeding, end up in organ failure, non-liver related organ failure. That's the blue graph. You see the acute insult and a fairly rapid decline over often just a few days. And if we are able to stabilize the patient, reverse their organ failure, they may recover, or they don't, and then they usually die very quickly unless we do something about it. We do know that the more organs fail, the worse the outcome. So this is very old data, as you can see here, a 90 mortality by the time 4 organs fail. And that's been reproduced in a number of studies. And as you can see, once you reach ACLF grade 3, as in apart from your liver not working, 3 organs failing, your mortality rate is anywhere between 80 to 100%. So pretty poor outcome. Yeah. And then it is also very costly. So you can see here the daily cost in the UK. That's the tariff cost of what I get paid if I run an intensive care unit per bed, and we are paid by the more organs failing, the more money you get. So up to £2,700 a day, and that may actually not cover the actual cost. But the more organs that are failing, the more expensive the whole thing becomes. So not only we are talking about quality of life, the suffering of the patient, but also a huge cost to society. So for ACLF, we've got defined treatment goals, and they're usually supporting organs, trying to intervene with the precipitant, the bleed, the sepsis. But often, we are bridging to nowhere. The patient's not getting better, organ failure is not reversed, and we're ending up in a situation where we need to really seriously ask our question, do we continue or do we stop? There are some pragmatic ways at looking at that, and I know Jack is giving a talk later, I think, in terms of a trial of treatment, a trial of ICU, and you see a bit of that here. 48 to 72 hours, we reassess the patient, and if they are not improving, we may consider, or at least discuss, is continuation of organ support appropriate. There are special circumstances in blue there which usually lend themselves to rapid improvement, and we wouldn't end up on the right-hand side of this graph. I'm not entirely sure if I like that concept. This is what we often talk about to our networks and the referrers, and that, yeah, we'll take the patient, we'll have a trial of ICU. But often what we find is we see some improvement, but the patient's actually not recovering, not getting really liberated from organ support. And then we turn around and say, well, how long do we wait? 48 hours, 72 hours, a week? And then it is often also the relatives and the family coming, well, why can't we have a transplant? You try and explain, well, it's not that easy. Organs don't grow on trees. And I say, well, isn't there also the option to donate part of my liver, living donor liver transplant? And you say, well, survival chance with a transplant is very, very low because your loved one has got multi-organ failure. And even if you mention 10%, which, statistics and percentage numbers is always a bad idea to really communicate with patients or relatives, I would say. And they would jump at that and said, well, 10% is better than 0%, isn't it? So what do you do then? Adverse predictors in general, so we've seen organ failure, and then I think we're hearing also later on about age, and I presume we also hear about frailty and comorbidities. I showed this slide yesterday, and talking about ACLF and the poor outcome, and often a bridge to nowhere. Well, this is a trial which has just been published by one of my colleagues, and it was a nationwide prioritization program for acute and chronic liver failure with fairly strict inclusion criteria. And you see the exclusion criteria on the right-hand side. Age, frailty, all these things we've talked about, multi-organ failure if not refractory or too severe, certain infectious processes, active sepsis, and obviously malignancy. But for the patients who manage to get a transplant, and we have got varying ways of listing patients for transplant, so there is a super urgent, we call it, pathway for emergency liver transplant for acute liver failure, hyperacute liver failure, whereby a liver usually becomes available on average, I would say, between 24 and 72 hours. And for ACLF now with organ failure, there is also a prioritization process just below super urgent transplants, which usually makes the patient wait for about 2 to 3 days within this trial. And as you can see, the patient who managed to get transplanted had an excellent outcome. More than 8% survived, whereas all the ones who didn't died. Right. So frailty is very important, and when we're talking frailty, we're talking about muscle and sarcopenia, and as you can see here, the odds ratio in terms of outcome is worse with patients who are frail and haven't got any muscle compared to age or even cardiovascular disease and stroke. And this is sort of exemplified here on this graph. You see on the bottom transplant responsive, so these would be liver problems we can easily fix with a transplant. And then in gray, transplant non-responsive factors, the ones we've just talked about, and frailty being one of them. And you see the pre-transplant vulnerability and the outcome after transplant. So clearly patients who are frail and very old with lots of comorbidities do very, very poorly after transplant. Acute liver failure, something very different, and there is UK national listing criteria, as you can see them here. They differ depending on what the etiology of the insult is. Obviously, usually it is quite young patients, so certainly for hyperacute liver failure, it's predominantly paracetamol, so they would be in their 20s often, or younger than that. The rate of disease progression, how ill there are from a multi-organ failure perspective, and markers of disease severity, as you can see, encephalopathy, renal failure, coagulopathy. Problem with it, we've got a sensitivity dilemma with any of the acute liver failure prognostic criteria. So we can't identify sometimes patients who would actually do without it. And transplant-free survival has been improving over the last few years. So we may waste organs and subject patients to an intervention, which is a transplant with lifelong immunosuppression. So this is the UK standard for transplant benefit, 50% survival at 10 years. It obviously differs depending a little bit on what the type of graft is and whether or not it's an emergency transplant or not. And in fact, these are super urgently listed patients. You see a funnel plot on the left-hand side and the various transplant centers in the UK, and King's there at the top. So doing pretty well with more than 90% survival over a year. See some American numbers which are slightly older, but that's only 21 days survival. But outcomes, even with super urgent and non-elective cases, in excess of 90% survival at 1 year. We've quoted in the past always 70% survival, but it's pretty good. I've talked about the cost of transplant and it being a precious resource. So these are just some figures in terms of the financial costs. But then there's obviously also societal cost, in as much as we've got too many patients on the wait list. And at any 1 year, 20% do die. So if we give the organ to somebody who doesn't benefit from it, somebody else will die who could have had a benefit, right? And there's a moral cost of the family who is agreeing to donate. They would clearly want that organ is used in an appropriate way. And I've already said, well, doc, I'm going to offer my right lobe, so what's the problem? That's not a cost to society, but don't forget, this is a healthy person undergoing an intervention which they don't need, from which they could die, and mortality is underreported, and certainly they could have lots of morbidity from it.
2 minutes.
Profound cardiorespiratory failure on that table is something which is considered a contraindication for transplant in acute liver failure, and we could debate all these numbers which are quoted there. The reason why we are very worried about shock and ARDS especially is because it will potentially cause problems with graft perfusion, graft congestion if the right-sided pressures are very high, and if there's cardiogenic shock, forward flow into the new organ, and graft failure. But, nowadays what we sometimes do is this: put patients onto ECMO. This was a young girl, 18 years of age, after a paracetamol overdose. And I will really rush through these. This is just a few examples of what we've done over the last 10 years. So we've had 21 patients with genuine acute liver failure who ended up on ECMO, predominantly VV, and half of them were bridged to transplant. They were all quite sick. Many of them had arrested prior to being put on ECMO. They were all on renal replacement therapy, high-dose vasopressors. Many of them were plasmapheresed. Some of them had ECPR. Biochemically, as you would agree, I guess, with me, they were very deranged. But, you know, we got some of them through. Hospital survival at the bottom end, 42%. You may say that's not that many out of 12. Most of them were weaned off ECMO and had good graft function. But one of the problems, obviously, is I showed you the funnel plot earlier. Look at where King stands once we're doing lots of ECMO. And if ECMO patients die, and your surgeons won't be happy with that, neither will your transplant hepatologist. Suddenly you're ending from the top hospital in the more bottom corner. And the other problem is that some of these patients end up with horrible complications like here. If we can play the video quickly, I know, half a minute? Finished. This is invasive aspergillosis. I'm not sure if you can play the clip, which was initially diagnosed on echo. So this is a midesophageal four-chamber view. You see that vegetation, the hand of death waving, I would call it, and then a biopsy specimen and the lung lesions going with it. But then, you know, we do this because we've got these wonderful examples of survivors. This lung boy was bridged to transplant, Wilson's disease, and a peripartum lady who needed a transplant and needed ECMO to get her through the transplant. Other moving goalposts, malignancy, you know, something which was never have dreamt about, putting something or subjecting somebody to a liver transplant if they have got cholangiocarcinoma or colorectal metastases, but all of this is now possible. And we're going back to the beginning, the common conflicts, and I presume you are very and most familiar with these and the issues in terms of talking to families about limiting healthcare intervention. I presume it's very rare in this country that you have got advanced diuretics, living wills, people saying, well, actually, doctor, I don't want to be resuscitated if I end up intensive care on 6-organ support. Or indeed have DNAR already in place for treatment escalation plans. So decision-making regarding futility in liver failure is multifaceted: clinical assessment, scoring, prognostic systems, ethical consideration, and then, most importantly, I guess, empathetic communication with relatives and patients. And I presume that's the same here as it is in the UK or anywhere else in the world. Future directions, continued development of predictive tools for futility in liver failure. I haven't really talked about palliative care options, but we may hear about those later. And I presume one of the most important things is education of clinicians. I think it is an area of medicine which is often neglected. We don't really learn. It's something uncomfortable to do, and we don't want to get exposed to it, yet it is really of utmost importance, and how we communicate with patients and their relatives. Sorry for overrunning. Thank you very much.
Thank you very much. Thanks, George. Thank you. We'll leave a question to the end. Now it's my pleasure to introduce Prof. Theodore Iwashina. He has been introduced many times throughout the 3 days. I'm just going to say that he is a distinguished professor of social science and justice and medicine at Johns Hopkins. He has a primary joint appointment in both pulmonary and critical care medicine in Bloomberg School of Public Health. I think that's enough. The rest,
that's more than I deserve,
Please.
so thank you.
Go ahead.
All right.
You have 20 minutes. Thank you.
All right, I've come down to 19 and a half because I'm counting your introduction. So thank you guys, right? It's the last day. We're running down to the bare, I'm running on fumes. I assume you're running on fumes. And we're here to do some of the foundational work, right? That's at the very heart of what we do, where what we do touches the sacred, where what we do addresses foundational questions of what is human life, what are our obligations to each other, and how do we trade those off. And I was given the enormously uncomfortable task of talking about something called time-limited trials. So I'm going to present some recent work out of the American Thoracic Society, of which I was not a part, that defines what a time-limited trial is. It's going to talk about the problems these TLTs, time-limited trials, are intended to solve, and it's going to be frank about a whole bunch of your problems that they're not going to solve, because they're not. Then I'm going to talk about that one study that was published in JAMA Internal Medicine that seemed to show that introducing time-limited trials can result in a 25% decrease in your length of stay, which would result in something like a 30% increase in your ICU capacity just by this one simple trick. And I'm going to tell you why I don't believe it. And then I'm not here as an American to wander into the incredible nuance of the hospitals that you guys come from and tell you fundamentally how to change your family communication practices. What I am hopefully going to do is try to give you a way to drop time-limited trials in there as a specific communication tool that you can use to help solve one problem that may move forward. And frankly, I'm going to be more optimistic than my previous colleague was, in part because I'm an American and he is British, and so I can be direct in a way that I think would mortify him. And so we'll see how that goes. There's a chance you'll need to code him, Margaret, if I make him vagal too hard. So this is the paper, the Defining Time-Limited Trials for Patients with Critical Illness, an official American Thoracic Society workshop. And we're going to start with just the text because I think starting with the text is a really useful component. I'm going to also note, again, this is a deeply American approach to this, and we'll talk a little bit about ways to generalize it. So the approach has been described as an attempt or trial of life-sustaining therapy with specific agreed-on guidelines designed to help clinicians, patients, and surrogates evaluate whether the therapy is providing benefit to the patient. These guidelines typically, these time-limited trials typically include a boundary on how long the trial lasts and clinical criteria to help determine the patient's response to therapy. After the trial is over, the patients, if able, surrogates, and the clinicians use these criteria to consider whether to continue life-sustaining therapies or instead focus exclusively on comfort. Operationally, they say, a time-limited trial is defined as a collaborative plan among clinicians and patients and their surrogate decision-makers to use life-sustaining therapy for an a priori defined duration, right? You set the time for the trial at the beginning of the trial, not once you're into it, after which the patient's response to therapy, which you also specify your stopping roles at the beginning of the time-limited trial, inform the decision to continue care directed towards recovery, transition to care focused exclusively on comfort, or extend the trial's duration. And of course, there's a WhatsApp chat that was set up for this, and as I started talking about this talk on a WhatsApp chat, I got some gentle feedback that full transition to comfort care, which although my American palliative care colleagues are going to be appalled by this, really is what we mean by withdrawal of care. We don't withdraw care, we only change our goals. What we mean is taking the pressors off, taking the ventilator away. I was told it's not the usual practice in Kuwait to withdraw care. Even on VA ECMO, if the patient doesn't recover and there's no possibility of a VAD or heart transplant, we just stop escalating care. We usually support them until they go into multi-organ failure, and then we limit their care. We do not withdraw. There are no formal rules here, but there's no withdrawal of life support. So one might ask the question, what am I even doing talking about this? And in light of this feedback, I went and texted Jackie Cruiser, who's the first author on the American Thoracic Society. And she basically said, my bad. You're right, we wrote this for an American context. And that every place that in that document that you have written the words limiting or comfort care, you could easily say limit care based on patient and cultural priorities, which could well involve continuing life-sustaining therapy and life support therapy, but not pursuing new clinical problems that develop, which may be a reasonable bridge in some contexts. Again, it's not my job to come in and tell you in your hospital what appropriate care is for patients who cannot be successfully bridged back to home from their therapies. Instead, what a time-limited trial is supposed to solve is the problem of uncertainty about whether a care plan will actually work to yield outcomes that are consistent with the patient's goals for an amount of suffering that the patient would be willing to tolerate. It moves us from us having to guess how the patient would respond and prognosticate and limit therapy at the front door to instead saying, well, let's see how they do, and actually getting patient-specific information. Now, there are problems this is not going to solve. In particular, it's not going to solve the problem of, I think I have no uncertainty about my prognosis, but the family disagrees with me. A time-limited trial, that's not what we do. It's not going to solve the problem that it's Friday, and if I admit this patient to the ICU, they need that bed for a post-surgical patient on Monday. Again, that's not whatever your strategy is for rationing, God bless, time-limited trials are not going to solve that problem for you. And I would also suggest that this should not be used as for the problem of, I don't like having hard conversations. So maybe if I start a time-limited trial, this will kick it to my next colleague takes on for my shift, and I don't have to deal with it. Because honestly, the first day conversation for the time-limited trial, if done properly and done honestly, is as hard as these conversations go. So fundamentally, time-limited trials, as I said, are about replacing best prognostic guesses, which are inevitably based on population averages, with patient-specific experience and information. So is there any data that they work? They've been proposed for over a decade. There's this piece from 2011 in JAMA, which is very much a state-of-the-art still, that goes through and actually lists for a range of situations, from the outpatient to the inpatient setting, how one might set up a time-limited trial, integrated into what Randy Curtis would still consider as gold standard end-of-life conversation, and move forward. So a group at 3 academic ICUs in Los Angeles County actually did this and published this paper in JAMA Internal Medicine. It was a pre-post study where they looked at 113 patients who are on ICU admission considered to have high risk of death by pre-specified standard SCCM criteria and compared them to 96 patients who received care in the ICUs after the start of the improvement. This was shortened by COVID, as so many clinical research studies were, and done at as I said, at 3 hospitals. And this is their primary result. On the horizontal axis is time since the start of the quality improvement study, with that dotted line running down the middle as the introduction of their time-limited trials. On the vertical axis is length of stay. And as you can say, there is an incredible, an unbelievable, an unprecedented, frankly, in critical care medicine that I can think of, reduction in length of stay from this sharp rollout of time-limited trials. And so you gotta at least ask yourself, since it's a pre-post study, are we sure the only thing they changed is the time-limited trial? And it turns out it's not. That honestly, I want you to start at that first box there. Day of ICU course, where the first time the family sat down and talked to an attending physician. And in the pre-period, it was 5.5 days on average before anybody talked to the family. In the post-period, it was 1 day. Honestly, I try to talk to all my new admissions families on the day they come in. Many of us do. It's been widely recognized. So if you're not talking to your families at all, time-limited trials may be part of a package that gets you to talk to families. And talking to families is probably better than not talking to families. Likewise, if you look, less than 1/3 of them, when they did have meetings, were discussing the risks and benefits of ICU care. That goes up to 95%. Less than half were eliciting values and preferences of their patient who they were taking care of for days on end. That goes up to 98%. I don't think of those as time-limited trial features. I think of those as gold standard end-of-life communication and family communication. The time-limited trial part does increase dramatically, where they actually identify a priori improvement markers. This is how we're going to know if critical care works. This is how we're not. And recommend treatment steps. If it works, we should keep doing this. If it doesn't work, this is how we would pivot. So as I said, I'm not here to fundamentally change your family communication practices. But over a few slides, I'm going to go through some scripts about how I have these conversations when I have them. That may or may not work for you. I found that I like it a lot because it helps clarify. So who do I do it for? I do it when I have genuine uncertainty. If I think this patient has urosepsis, needs a little bit of fluid, some antibiotics, and is going to do great, I am not having a time-limited trial conversation with them. I'm going to tell them, I think this patient has urosepsis. They're going to give them some antibiotics. They're going to perk up in a day or two, and we expect this to go great. Likewise, if there's a patient who we think there's no hope of survival for, I'm going to tell them straightforwardly, we have no hope that they're going to get out of the ICU. Let's talk about what a good dying process for them looks like. But when I'm in that middle, where I don't know if the therapies are going to work, this is a great tool I find for clarifying my own thinking and then helping us work together. In order to do that, I need to figure out beforehand what this patient and this family would consider unacceptably bad. Because frankly, I think of time-limited trials as often a process for helping families understand that they have tools to spare their loved ones from unnecessarily invasive care that, exactly as you were saying, would be undignified and incompatible with their values. So I have my first conversation, and then I say, look, we've got to talk about some hard stuff. Here's the basic script, the stuff in red. I'm going to give you a specific example. You'll slot in your patient-specific fill-in-the-blank otherwise. I'm baffled as to how stereotyped I am at this because I do it 3 or 4 admissions a day, every day I'm on service. So the biggest threat to their life right now is, for example, septic shock from their lung infections. We are giving them antibiotics, steroids, and checking for an infection around their lung, what might be called a peritonic effusion, to treat that septic shock. Look at all the things that we are doing for your loved one that constitutes giving them the best possible care that they could get anywhere in the world. And if our therapies work, I'd expect to see them get off pressors by 72 hours from now. I'd have to explain what pressors are at this point. If our therapies are not working, though, we'll know because they'll develop new organ failures, and I won't be able to quite get them off pressors. Indeed, the number I'm going to be looking at is this number that's labeled Levo on the pump right there, right? It's also called norepinephrine, and our patients tend to get stuck on 0.01, 0.02. That's not a failure. That's just, my youngsters don't like to resuscitate patients enough. But as long as, if that number is higher than that, they're still on pressors. And I will actually teach them how to interpret some of these numbers. And if our therapies do not work, then, as we discussed, your loved one wouldn't want to stay on these machines. They always said being dependent on machines was unacceptable to them. So we'll have to transition to comfort care. If I have to explain to you what comfort care is, I promise I will. So how do I decide what my thresholds are? I'm pretty transparent. Honestly, I have this conversation with every one of my fellows on every patient when we do afternoon rounds, right? I expect my fellows to know what the expected course of recovery is for their patients and what an off-trajectory course would be that indicates that our therapies are failing, so they know whether or not to intervene. And I tell the families the same thing I tell the fellows. I tell it in a less technical language, but I tell it very straightforwardly. And so if we do that, then I'm updating them every day, and honestly, half the times they're at the bedside and they're staring at the norepi, and they know exactly what that next conversation is going to be, and they've had time to begin to process it. And I say, all right, so it's been 72 hours since we last met. The biggest threat to their life has been their septic shock from their lung infection. We've given them steroids, we've given them broad spectrum antibiotics, we made sure there weren't any other infection sources to treat that septic shock. And 3 days ago, we talked about what success and failure would look like. And now, the patient's on 3 different pressors, is in kidney failure, is in respiratory failure, and in disseminated intravascular coagulation. Obviously, I'd explain all those. Those are all the organ failures that we said might happen if our antibiotics weren't working. So as we discussed, we need to honor their wishes and make sure we're transitioning to comfort care. For them, what you told me would be that we'd keep doing what we're doing now, but we wouldn't pursue yet more problems. Often it's a natural place to set a limit on dialysis, set a limit on potentially going after a GI bleed or some other potential multi-organ failure or perforation that we believe is not going to do any good for them. You have to believe all those things. This hinges on your medical recommendation as to whether those treatments are useful or not. If you believe they're useful, then you should ask real hard how you got yourself into this time-limited trial, that you may not have specified the right conditions. So I was asked to talk in part about how we standardize this, and it's just hard. But on the other hand, we do hard things in our collective practice all the time. We come to collective decisions about when we intubate patients. We come to collective decisions about who's a transplant candidate, who's a dialysis candidate, what we're going to do with delirium, what our early mobility is, what our feeding protocols are. The way we do that is by talking through shared cases to figure out what we agree on, and where there's enough disagreement that, frankly, if I'm thinking about a time-limited trial and I'm going to be handing off to somebody else, I need to consult with them in advance to make sure that we have a coherent messaging strategy that bridges across that discontinuity of care. They're not an all-purpose panacea, but they may, in some cases, help you talk about what the future looks like and give families time to think when they're not in the heat of the emotion about what good outcomes look like, what bad outcomes look like, and how to choose often among the least bad situations, because you're obviously, if you're in this conversation, you're not talking about good things. Thank you very much.
Thank you. Now we would like to call our next speaker. She is the head of Department of Health Science, Brunel University of London, national and international leader in nursing, care and ethics, committed to professional education, innovation, research that contribute to excellency in health and social care. She is a Fulbright scholar, hosting center fellow, and editor-in-chief of International Journal Nursing Ethics, and author of over 170 publications, including 6 books. Please welcome Professor Anne Gallagher.
Thank you. Thank you very much. Thank you, Professor Haddad, for that introduction. Thank you. A great pleasure to be here. I think it's heroic that you're still here. We're just standing between you and the closing ceremony, which I very much look forward to. Just an overview of what I'd like to cover in this session, and there's also, there'll be some complementary overlap with the 2 previous speakers, which is always very helpful. So again, thank you for the invitation to be here and for your amazing hospitality. It's been a great pleasure. This is my first visit to Kuwait, and I fully intend to come back. It's been fantastic. A little bit about where I work, Brunel University of London, and then I want to talk about some of the contextual factors which underpin ethical decision-making in your area of practice. And then I want to go on to say a little bit about approaches to ethics, with the proviso that most of what I talk about will be more of a Western perspective, and I'm working with Professor Haddad on remedying some of that, particularly in relation to nursing. And then I'm going to introduce 2 decision-making frameworks, which I hope will be helpful. Some may be familiar to you, and it's something I think we could do more on to work up helpful ethical decision-making frameworks in critical care. So this is where I work. I work at Brunel University of London, which is very near Heathrow, just about similar distance from here to Kuwaiti, the Kuwaiti airport. So we're literally 15 minutes from Heathrow, very near central London in the west of London. We're joined first UK University for International Outlook. We have 18,000 students, over 2,000 staff. It's really great because it's a one-campus university, research intensive, and we have a very strong commitment to the values of diversity, inclusion, and also to professional education. So my department, we have 5 professions. We have occupational therapy, physiotherapy, nursing, social work, and global public health. We also have a brand new medical school at Brunel, just in its 3rd year, so that's very exciting, and lots of opportunities there for interprofessional education, which is really very important, particularly when we talk about ethics. We also have advanced critical care programs and executive leadership for health and social care professionals. And I put this up as well, I'm editor of the journal Nursing Ethics, so that's is based at Brunel, and I'll come back to that a little bit later. So there's lots of contextual factors when we think about ethical decision-making, particularly in relation to critical care. Some have already been touched on, It's almost a cliche now. We talk about potentially infinite demand and finite resources. And we saw this most acutely during the COVID pandemic. And I know many of you were, as it were, at the coalface negotiating some of these great challenges. Who gets the ICU bed, who gets the ventilator, who gets the oxygen. Limited resources and hard choices had to be made, hard ethical choices. And of course, what we also saw is that professionals are very, very good at being resourceful and being creative. So we saw lots of innovations, for example, of professionals making it possible for patients in ICU to communicate with families. A very, very painful and difficult time for people who had loved ones in ICU who couldn't see them. Other contextual factors, we need to reflect more on cultural and societal norms. I'm acutely aware where we are, and as I said, our ethics, a lot of the literature on applied ethics in healthcare has very much a Western orientation. So we have a lot to learn from different cultures, the Middle East, the Far East, and also southern countries. Another contextual factor is research and technological developments, which include AI. There's been some fantastic conversations at this conference on the role of AI and how helpful will AI replace the ICU team in the future. So lots of very interesting and controversial conversations. And I suppose for us in ethics, the question is, just because we can do it, should we? And what are the implications of pursuing some of these technological developments? Another very significant challenge, and also you could say an opportunity, relates to the accessibility of information. We have a lot of fake news. Patients are often very confused. In fact, professionals may also be confused by a multitude of information coming from very different directions. So the reliability and accessibility of information impacts our ethical decision making. And of course, all of us are engaged with responses to significant demographic changes, an aging population, to multimorbidities, and also, of course, our concern with inequalities in health and public health challenges. In terms of professionals, one of the reasons ethics is on the curriculum at all is because we're registered and we're accountable and we have certain professional status. And I'm going to come back to the issue of trust in just a minute. But critically for the session today, I want to highlight the importance of recognizing the value of interprofessional working and learning and mutual respect. Again, COVID, I think, has done a lot, certainly to raise the profile of nurses and other health and social care professionals alongside our medical colleagues. So we want to build on that and do more. The issue of trust and mistrust are two very, very important concepts, particularly at this time in relation to professional ethics. This was an article from The Guardian, the UK Guardian, just this week. It was a commentary, and the doctor, Miriam Tokai, she says, "We're seeing anti-medical, anti-science narratives everywhere. How can doctors like me respond?" And I see some nods in the audience. I think that won't be a surprise to you. Alongside that, we then see reports like this. Nurses are voted the most trusted profession, which is fantastic. However, we still have lots to do. There still is a good deal of mistrust. During COVID, this is a really great paper from the New England Journal, Trustworthiness Before Trust. Some colleagues from Tuskegee in Alabama did a paper, and it was so interesting. The question is, why aren't African American populations coming forward to take part in vaccine trials? And the paper, the gist of it is, well, it's not why don't they trust us, it's why are we not demonstrating that we're more trustworthy. So I think whenever you think about particular African American populations in the United States, they still go back to the Tuskegee the syphilis trial at Tuskegee. That's still very much in their consciousness. So we have work to do as professionals, as researchers, to build trust with our communities and to reassure them. This is a lovely Eric Topol, I love the title of this book, The Patient Will See You Now, which I think is a really, really great title, just demonstrating a shift in the way we are and the way we relate now to our patients. And again, AI enters AI. Again, mistrust, there's much hope about the potential of AI to make things better in healthcare and in critical care in particular, but also a lot of anxiety. In nursing, there's a lot of discussions about care bots, and we've also had discussions at this conference, indeed, as can a robot, a care bot, replace the human touch? I'm not going to say any more than that. I do, of course, have a view. So ethics in healthcare. Ethics is an integral part of healthcare. Brilliant, fantastic to have this session. Concerned with doing the right thing and with the development of good character. Critically, ethics is not new. It's only really since the 1960s in the United States we had the immersion, the development, the beginning of bioethics. But people have been writing about ethics, particularly in relation to medicine and more recently in nursing, for quite a long time. It's an ever-evolving field. It's very exciting, lots of exciting developments, both philosophical and in terms of empirical ethics as well. It's advanced most effectively, I'll say it again, by interprofessional learning and interprofessional working. And there's a huge literature, just to give you a flavour of what people are writing about. Many of you, the first speaker just mentioned the principles of biomedical ethics. Again, it's been evolving that approach since the 1970s. We also have a colleague, Jingbao Ni, lives in New Zealand, has written a book on medical ethics in China. I was delighted to find this book on Muslim medical ethics. And of course, we're also beginning to look at what indigenous populations have to offer us. We've been somewhat myopic that our Western approach is the best and the only one. Of course, that is not the case. So lots to learn from other perspectives. So now I'm really pleased that in our conference in 2 years, we're going to look in Canada, we're going to look at more indigenous cross-cultural perspectives. And just last year, Marcia Fowler published this book on nursing ethics, going back to the 1900s. There's a huge literature which is so interesting, and also, of course, in medical ethics. At this conference, although this is the first session that was explicitly titled Ethical Challenges, ethics is everywhere. I mean, I see it everywhere. There's been, at every session, people have been declaring their interest as an ethical matter. There's been lots and lots of discussion about how we weigh benefits and harms in critical care, lots of interesting discussions about prioritizing patient and family perspectives. There's been highlighting much discussion of the importance of ethical leadership, role modeling, good teaching, and examples of professional agility, courage, and humility. And I've mentioned the journal. The Journal of Nursing Ethics was 30 years old last year. It's now in the top quartile of journals. The Journal of Medical Ethics precedes that, and of course we have other journals in bioethics as well, which are definitely worth a look. So in terms of approaches, the first speaker has been very helpful at giving an overview of the 4 principles. It's often criticized, particularly in nursing and care. They say, oh, you know, it's not a good fit. I think it's a very helpful framework. However, it's Western in orientation. As has been said, autonomy, particularly individualistic approaches, are not always a good fit for other cultures, so it's something that needs to be adapted. So you have respect for autonomy, do good, minimize harm, and treat people fairly. And in fact, justice, these concepts all have a lot of complexity, but justice is probably one of the most complex principles. What does that mean? Do we allocate, we mentioned distributive justice, we think about how we allocate organs, we allocate tech, as I said, respirators and so on. But it is quite challenging, but it also, justice and fairness also relates to non-discriminatory practice. And I constantly remind at least our students, you are also a precious resource. How you spend your time is really very, very important and very pertinent and requires reflection. Do we allocate our time? How do we, for example, engage with people of different race, class, gender, sexual orientation, class? It's very much a reflective piece. So we are a precious resource. We allocate our time in a prudent manner. Complementary approaches, duty-based ethics, that is about our codes, and I was also very pleased to hear there is a code for nurses in the Gulf, which is something that we can draw on. We have international codes for nurses, doctors, and other professionals. We have rights-based ethics, consequence-based ethics, and in fact, you will be aware that consequence-based ethics, it was really at the forefront of the pandemic. We moved more to a public health ethics, a consequentialist ethics, asking not so much what do we do for the individual person, although that decision had to be made. It was very much what is going to do the most good for the most people, which was very, very challenging as well. Virtue-based ethics, what ethical qualities do I need to be a good healthcare professional? And again, you've heard repeatedly, many of these qualities throughout this conference, being respectful, being honest, courageous, compassion, empathy has already been mentioned. Courage twice, it's important, excuse me. Justice, trustworthiness has been mentioned, and being prudent, demonstrating practical wisdom in our everyday activities. And mercy, Dr. Eli gave a really lovely talk day one on the concept of mercy. So, moving on, what is a decision? I was asked to speak about ethical decision making, specifically in relation to nursing. Everyone knows what a decision is. We make decisions all the time. We enact many. Sometimes they relate to action, sometimes to omissions. Our moral decisions, clearly there's an overlap between our clinical decision making, our scientific decision making, and our ethical decision making. But a moral decision is very much dependent on our ethical considerations about what is good and right and values-based. So often when you see should, must, ought, we are often in the territory of ethical decisions. We have to give responses to some of these challenges. Many of us may not feel morally prepared, ethically prepared. Moral blindness, there's quite a literature now on moral blindness, which is really interesting, because the view is that sometimes you can see the clinical aspects, particularly in critical care, but the moral aspects may be less prominent. We may have a blindness to the ethical or moral considerations. Moral fanaticism is where we know what is right, we're going to do this, it's save life at all costs or not. So moral fanaticism is something we may have to work with each other and ourselves to negotiate and to resolve. There are many moral disagreements, moral dilemmas. Moral distress as well has a very high profile concept, and that is where we feel one view is, one definition, we know the right thing to do, but we feel unable to do it. There's a very significant literature, and it has very detrimental consequences for professionals. Some doctors and nurses leave. They're unable to sustain practice because they feel they cannot do the right thing. They have to constantly make compromises, and they're not able to deliver the quality of care they feel they ought to. Critically, in ethical decision-making, in critical care, we need to think about relationships. Certainly, nursing and medicine, I would argue, are both relational and moral practices. We need to prioritize relational perspectives and think about those relationships that have already been referred to in our last talk, for example, about having communication with families, how we negotiate the relationships, often when a patient is not able to speak for themselves. So negotiating those relationships are very central to our ethical decision-making in critical care. So, get in there. I'm going to share just two frameworks. There's lots of ways of thinking. The last one, thank you very much for how you conduct a conversation with a family. And it would be very clinician specific, but based on the facts, but also the values of our practice. So this is one framework that we might want to think about. I love an acronym, so the Ethics Deliberative Framework. So we start with, of course, what are the facts of the case, the situation, and we always need to know more. We often would say, well, it depends, we need to know more. Then we think through the options available to the people involved. We hear the views of the people involved. And whilst it is the case that many of your patients may not be able to express a view, sometimes people can be very creative. There was a case I work with. I used to be a member of a hospital ethics committee, and they talked about a patient. They were in critical care. They decided to move to palliative care, and the patient, it was known that they wanted to die at home. And the partner was involved in the conversation, but the doctors wanted to be sure this was the patient's view. And one of the care assistants had found out that the patient was able to communicate by squeezing her hand. And the patient was able to squeeze her hand. They wanted to be sure this is what she wanted, and she was able, once for yes and twice for no. Now, that's a very simple example, but clinicians have that capability to find creative strategies to communicate, to find out what really matters to patients, particularly towards the end of life. Really very, very important. So we hear the views of those involved. It may be, the other clinicians, maybe the care assistant, certainly family, and where possible, the patient. And then we need to identify relevant principles. Mention the 4 principles, respect for autonomy, beneficence, non-maleficence, justice. Dignity has been mentioned. Dignity is a very important concept in all areas of care practices. And then you would also think about the virtues that we need, demonstrating compassion, empathy. Clarify the meaning and the implications of values. And critically, Why worry about ethics at all? Well, because it's a fundamental part of our accountability. We need to justify what we do and indeed what we don't do, both our actions and our omissions. So that rounds off the process. But then we reflect again and we begin the cycle. Some hospitals, particularly in the United States, will have a hospital ethics committee, clinical ethics committees. These can be really useful. They're not so rare, they're quite rare in the UK, and I assume, and I don't know, do you have clinical ethics in Kuwait? No, okay. I mean, they're considered as complementary to clinical decision making. Some areas do find them really very helpful. They also, you see, have different functions: educating the team, case consultation, obviously, but also policy and community engagement. The last one, I'm nearly at the end. This approach is very well known. If you do Google any ethical decision making, particularly medical practice, you will arrive at the 4-quadrant approach. It's different whether the last approach was more process. This one is more, these are the considerations. A very nice fit with the 4 principles approach. So these are the 4 areas we need to think about in our critical care decision making. We need to think about client preferences, so there's your autonomy box. We need to think about medical, and excuse me, I would also put family there, so client and family preferences. We need to think about the medical and clinical indications and the benefits and the harms. We need to think about quality of life. Again, our first speaker talked in some detail about quality of life in relation to futility, and I guess we'll be hearing a little bit more from the next speaker in relation to futility. And lastly, thinking about the contextual features. Very, very important in any decision making, we think about the contextual features. It might be about resources, it might be about the ICU, but there may also be cultural or societal considerations that we have to think about. And there's a number of articles, very happy for these slides to be made available. So just to conclude, we reflected a little bit on some of the issues that impact ethical preparedness in our changing times. There are many moral challenges and relational dilemmas. I don't need to tell you that. You live this every day in your critical care practice. The importance of leadership is really important. We had a discussion this morning about the importance of ethical leadership and role modeling, where leaders really show the way to colleagues who are less experienced. That's very important. They role model the good communication, engagement with family and patients. And ethics education, of course, is also very important. So people have that ethical preparedness. There are decision-making frameworks. I've shared 2, but there are many others. So a quick search, you can bring up others. And in terms of what the conclusions I would draw, ethical decision-making for nurses and other professionals, it's necessarily shared and collaborative. It's necessarily interprofessional, necessarily non-hierarchical, although there are hierarchies, of course, and cross-cultural. We need to be attentive to the cultural specificities. And as I said, a lot of what I've shared, I'm acutely aware, many from a more Western approach. And also our decision-making needs to demonstrate humility. I have been to many sessions in this conference where our colleagues were sharing their humility and realizing that maybe we didn't do it right that time, but we're willing to learn and we're more open-minded. Also, we need to demonstrate agility, person-centeredness, prudence, and that word again, trustworthiness. Thank you very much.
Thank you. Now we would like to call our last speaker. She is a professor in the Department of Medicine and a senior scientist in Toronto General Hospital Research Institution. She is the director of the recovery program of the chronic critical illness at the Toronto Grace Health Center and co-led Canadian multi-center 5-year follow-up of patient caregivers after COVID-19. She is published 2 editorials and 4 manuscripts in the New England Journal of Medicine, including 1 and 5-year outcomes after ARDS, 1-year outcomes in family caregivers after prolonged mechanical ventilators. She is a frequently
read the whole thing.
International speaker on outcomes after clinical illness. Please welcome Professor Margaret S. Heritage.
Okay, that's right. The talk's over now.
You are the last speaker, so you take your time. Thank you.
Thank you. Well, thanks for the kind introduction, and just, Margaret Heritage from Toronto is perfect for me. So thanks to everyone for staying till the end. And thanks to my fellow speakers for excellent talks. I really enjoyed the session myself. And hopefully I can develop the discussion a little bit more about some of these ways that we stratify risk and inform some of these difficult decisions in the ICU. And was asked to talk about age and frailty as a limitation. I'm just going to turn my timer on here. Okay, so I don't have any conflicts of interest, and I already said I don't work with pharma or industry. So I just want to talk about a few things in the next 20 minutes. I want to emphasize something that may be very obvious to everyone, but age matters a lot. And it's not discriminatory or ageist to say that. It's really a biological fact. And this is based on a few things that I'll talk about in a moment. I also want to make the point that frailty matters a lot as well. And there are ways to, there's a lot of literature on this. I'm going to talk a little bit about that today. I'm going to emphasize yet again how we've de-adopted the 8F bundle, because I'm really wanting to message that. This is sort of a crisis in our specialty. And talk a little bit about trajectories of outcomes and some interventions. And also to talk really about the need increasingly for geriatric critical care. So maybe seems a bit like a strange thing, but with our aging patients, all of these issues become more and more germane and really important to talk about. So I wanted to highlight a really beautiful review paper in Cell from 2023. And this was a very nice review of the hallmarks of aging. And it's a great read because it really does outline the biology of aging. And the biology of aging really stratified into 12 domains and into a few major domains where we have primary processes that are related to genetic instability and telomere attrition, epigenetic alterations, and really a loss of proteostasis and sort of regenerative ability. I won't go through all of these, but the major categories are primary, antagonistic, and integrative. And it really fundamentally outlines the biology of senescence. And remember that normal aging is senescence, that when we get older, we lose organ reserve. That's normal. That's not pathological, and it's important that we keep that in mind as we think about our aging critical care population. So cellular senescence on the background of normal aging can be further exacerbated by acute or chronic damage, and one can only surmise, as intensivists here, that we're really talking about acute and dramatic organ dysfunction and organ injury. And what this does when we injure organs is it creates populations and accumulation of senescent cells. And that's not in and of itself a big problem, but our ability to heal or regenerate or repair senescent cells is an age-related phenomenon. And different studies outlined in this review, when you look at younger patients under age 25 as an age threshold, and I'm not saying 65 is old, but older patients more than 65, you really have a dramatic accumulation of senescent cells when faced with an insult. And this really does affect the fibroblasts, the endothelial cells. A great example of this was COVID, because it was a generalized, profound endotheliopathy and immune function. So this becomes very relevant to our subspecialty. And this senescence, the accumulation of senescent cells is really implicated quite directly in lung fibrosis, kidney disease. Dr. Ossinger talked about liver dysfunction, but liver steatosis, obesity-related metabolic syndrome, which was a very profound risk factor for COVID critical illness, diabetes, atherosclerosis. You see the sort of endothelial theme here. Alzheimer's type dementia, Parkinsonian disease. So the cellular senescence matters a lot. And when we look at senescence here, and I like these schema from this article, that in a normal physiologic state, when there's tissue injury, and that's what critical illness is, it's tissue injury on top of what you've already got in terms of chronic organ dysfunction. The initial issue is the development of senescent cells, as I mentioned. And these are then eliminated. So you really require a very potent immune response and an intact immune system to eliminate senescent cells effectively. And one of the processes of these is autophagy. And then this facilitates repair. So pathogenic or pathological processes, this fails. And it fails, and this results in disease, accumulation of disease and aging. And we all understand, who've done ICU for a long time, that a critical illness is progeric. It causes aging. Because what aging is loss of reserve and its senescence. And that's what's happening when we look after patients in the unit. They are unable to recover from generalized tissue injury. And of course, the oncogenic version of this is that we develop malignancy, we develop cancer cells. And when we're talking about tissue repair following an injury, we do really rely on a healthy microenvironment, a healthy extracellular matrix, and we rely on a certain degree of cellular plasticity to really promote that recovery and that repair. So this is going on in all of us all the time, and critical illness accelerates this injury and repair stress and the need for this innate resilience. And there are other age-related declines as well, and great to hear some wonderful nutrition talks at this meeting, because one of the important factors in age-related decline is dysbiosis, or loss of diversity of our microbiome. And our microbiome being very, very important and increasingly recognized as a risk modifier, a mediator of many of these health outcomes. Again, it's not ageist to say that we lose neuronal cortical density, and we have neuronal loss as we age. That's part of healthy aging on average. And there are very beautiful studies in ICU, in ARDS, some published by Mona Hopkins, showing an age-inappropriate cortical loss after a severe episode of ARDS. This is progeric. This is accelerated aging and loss of organ function. We know beyond the age of about 18 or 20, we lose a certain amount of our FEV1 each year with aging. It's imperceptible to those of us who enjoy good health, but it's very real. And that's why you don't see elite athletes doing certain sports that require, the Olympics, that require enormous cardiopulmonary reserve. It's not a thing because of aging. We lose a bit of our ejection fracture with aging, and we all understand that our glomerular filtration rate, our GFR, our renal function, declines over time, but it's imperceptible. We don't need dialysis. We have a ton of reserve if we're fortunate to enjoy good health. But all of this gets disclosed when we have a severe injury like critical illness. So aging is normal, and we lose reserve over time, and that's part of normal senescence. So how do we understand or how do we measure in other ways organ reserve? Well, some really wonderful work by Lauren Ferrante, who's at Yale. She's published a lot in this area in older patients, and published a lot of meaningful work in terms of how the functional trajectory prior to critical illness is enormously informative in terms of risk prognostication. So great and very critical to understand from the families, another reason to have families at the bedside, who was your family member before they became so catastrophically ill? Were they very high functioning? Were they already in decline? Did they need, functional assists and aids? These are enormously prognostic trajectories. Great and important to spend the time, pardon me, to get that history. It's really important to be a good history taker, even in the ICU, especially in the ICU, I would say. So there's a lot of great literature on frailty. Frailty is enormously prognostic in the ICU. Another reason to understand the history of the patient. Were they acquiring frailty? What state was this patient in? So I've highlighted a few papers here from a couple of my Canadian colleagues. Sean Bagshaw was here at this meeting. John Muscaderi, a colleague of mine in Kingston, Ontario. And I really would like to highlight a lot of the work from Bertrand Guidé and Hans Flotten and others, and some of the data from the VIP2 study, really looking at octogenarians and increasingly a group who inhabit our ICU. So here's some data from Sean Bagshaw's study published in the Canadian Medical Association Journal now 10 years ago, but clearly establishing that there are risk profiles for probability of survival based on frailty. And here you can see with the higher frailty score here in blue, with a frailty score of 6 to 8, a very potent signal in terms of the probability of survival and compromised survival with more pronounced frailty. Here's some more data, again stratifying frailty status, here on the y-axis though by the number of disabilities. And disability, or this declining trajectory that I show you from Lauren Ferrante's work, again, enormously prognostic, an important thing to pay attention to. This is a very nice paper by Nate Brunel, an American colleague of ours, and I really love the alluvial diagram personally. It's very instructive to show you the changes over time. It works beautifully with care trajectories as well. And you can really see here that during an ICU stay, in panel B, an overwhelming number of patients will have a worsening in their frailty status as a result of a critical care admission. So this becomes prognostic. This becomes informative too when we're talking about goals of care and talking about patients in whom there is uncertainty or a real concern that they are not going to survive to ICU for what they tell you is a good functional outcome for them, because it does vary a lot. I also want to talk a little bit about, or reference what Jack spoke about, and a little bit what Dr. Ozinger spoke about as well, a bit of uncertainty. And the clinical frailty scale helps to highlight that patients, after a trial of therapy or a trial of critical care, it takes many days to really understand the establishment of a new trajectory and a negative trajectory. And here, this very nice paper from the VIP2 data highlighted that, it's more like 5 days. This idea that sort of we'll see how someone is in 24 hours is really not giving people an opportunity to show you what trajectory they're ultimately going to reside in. So interesting 5-day threshold here. In our own Canadian Recover group, we were able to establish trajectories based on age, which I have to say I got a lot of negative feedback on this because it seems ageist, but I'm hopeful I've just shown you it's not. And ICU length of stay, which is its own marker. It's a marker of chronicity. It's really a marker of loss of organ reserve. And Jack gave a beautiful talk earlier on chronic critical illness, which fundamentally is a loss of reserve. Patients get stuck. This getting stuckness is prognostic. And also how the acute, and Jack also showed data about this, and here's another study published this year by DeLong and colleagues, showing that early on, the clinical frailty scale age, so I've just shown you these are very robust metrics, and the SOFA score are very important independent prognostic factors for 6-month mortality. And various geriatric syndromes or scores beyond this are not additionally prognostic. So we have a lot of information up front that can help us make decisions. Well, not help us make decisions, help us facilitate the family's understanding of what the goals of care are for their loved one. And here's another paper. This is led by Bertrand Guidé, and also just showing with these sort of tipping of the scales here that a fit elderly patient can take on a huge burden of comorbid illness or acquired organ dysfunction in the ICU, and thereby demonstrating their innate resilience. But you have a frail elderly patient who accumulates this dysfunction in the unit, and we all see this as clinicians. They fall apart. They decompensate, and you watch all of the systems tumble, one after another, as they show us their loss of organ reserve. That is prognostic, and that is progeric. Okay, so Bertrand and Hans Flaten and several of us, I was honored to be part of this sort of discussion group paper, really highlighting trajectories, and this was based on some earlier work that Ellie and I did, but as part of actually a roundtable, and Jack was part of that roundtable from several years ago, really highlighting different risk factors. Patients take a big dip. The older patients, and statistically really never get back to their prior baseline. And their ability to recover from this profound tissue injury, which is critical illness, really has so much to do with their innate resilience and their burden of comorbid illness and baseline functional status. And this is really just trying to illustrate that, again, with sort of this continuum construct. And here talking a little bit further in the paper about actually what's already been talked about here again, which is an emphasis about on communication and honesty about uncertainty, and spending a lot of time in discussion, building rapport, building trust, building a sense of honesty. I like trustworthiness. Dr. Gallagher, this is what we're trying to do, and we are really trying to understand not if a patient wants to be alive or not, but the state in which someone wishes to be alive. That's the bottom line, really, and that's not fundamentally our decision. I think personally we are facilitators, we are educators, and I personally don't talk very much about death in conferences. I really talk about disability because I want to help the substitute decision makers understand what the disability may look like so that they can tell me the degree of disability that might be acceptable to their loved one. Because it's very different, and some people may be very happy not being very mobile and watching television. And with all these streaming services, you can watch a lot of television, and people really get a lot of enjoyment from this. I'm not being sarcastic. I'm really being true. And not for me to say that that's not the life that I would want, but it's so important to try to educate people as best we can about what a life may look like with some of these very potent risk factors. So I'm just talking about age and frailty currently, but as the weeks go on in the ICU, acquiring more and more disability, which is a certainty. It's not an unknown, it is a certainty. And how people are able to recover and what would be fundamentally acceptable.
2 minutes remaining.
Yeah, so just for some final thoughts, and I talked a bit in some earlier talks about how everyone is getting older. The population is really getting older. This is a major issue because we will have octogenarians in the ICU. We already do. And it's important to think about these issues and how we're going to manage it and how we're going to counsel people. And people aren't just older, they're more comorbid because we're very, very good at looking after patients with multi-system chronic disease. And it changes a survival and it changes a lifetime. But all of that chronic disease is disclosed when you become critically ill, and we all see that. And I hope I've convinced you that age and frailty matter, and not in a discriminatory way. It's just fact, it's biology. So premorbid functional status matters a lot. And I emphasize with our trainees in Toronto, please take a very complete history. It's so important. Talk to the family, ask them what this person was able to do. And like really seriously, not, well, they walked to the store. Well, drill down on the details. What could they really do? And find out the information. And trials of limited therapy, which Jack addressed, and which I've sort of indirectly tried to inform, requires so much discussion and honest discussion, truthful discussion about uncertainty. And I think communicating uncertainty is communicating humility to the family, that you're willing to be honest with them. And that really, I think, also lends itself to trustworthiness. But it takes a lot of time. But we've got time for things like this, I think. That's our job. That's why we do this. The other thing I want to say, and I've learned a lot from Bertrand and Hans in some of these collaborations, and it's so true, elderly patients value quality of life and functional independence. This is what they want. They're not interested in talking to you about survival. They're interested in talking to you about function. So I think this is why it's very helpful to talk about disability and frame the discussion around disability. We are so vulnerable to deviations from best practice. May I say again, it's mandatory that we observe this as we continue to develop and understand this, and be very mindful of what we do every day in the unit. And I say this to our trainees, every decision you made today, maybe the glycemic control wasn't tight enough or whatever, and you go, well, no, it all adds up. It adds up to a better or a worse outcome, better or worse functional disability, cognitive dysfunction. All of these things matter because you're not going to see this person a year from now. Or you may if you do follow up, which I encourage. But it matters a lot. And we need to be very mindful of all these decisions as part of a larger and broader construct of the ICU care continuum. And with that, I will say thank you very much, and pleasure. Okay.
Thank you very much. I would like to invite the speakers to the podium, please, so we can get some questions. Just one more is enough.
Going out.
Yeah.
That's amazing.
Yeah. Yeah, okay. Okay, any questions from the floor? Jack, I'm going to ask you a question. So you have a patient that you admitted to your ICU, and you decided, okay, I'm going to give them a trial of care, 48 hours. You are now at the 48 hours. You are not there. You don't see things moving in the right direction. And you need to say, okay, I think this is the time to shift gear, and then let's take another venue where sort of comfort care. But the family insists on continuing. What would you do?
Thanks for the softball. Really appreciate that. So I have the privilege of working at an institution that is almost never actually maxed out, right? So we are occasionally full, but when we're full, there are always some patients waiting to go to the right. So during COVID, a lot of us discovered what actually at capacity was. And it turns out actually at capacity is usually like way more than when we say we're full. And so I think that's an important distinction. So I'm going to give you the example I'll give you an answer under normal operating procedures, where the only reason we can't actually accommodate another patient, where I have to literally choose between two lives, is a budgetary concern, not a literal inability. So I gotten old, and I've decided I'm not really in the business of telling people what kind of lives are worth living. And so my general view is, in most cases, if the family can convince me that this is something their loved one would value, not just that they're not able to grieve, I will defer to them. In particular, because in the particular clinical context that I often practice, those conflicts are across racial lines, and I am at a place in my life where I don't want to tell another black mother that her son's life isn't as important as she says it is. And I think the harms of overriding that for the family is often worse than the harm of us doing another couple days in the ICU.
I guess a lot is down to how to frame the conversation. So I rarely nowadays talk about withdrawal of care, but shifting emphasis of care. Comfort care, making sure that the loved one, the patient, is most comfortable. At most, you would say maybe non-escalation of care, not even withholding care. And I think it is very true, and you've both mentioned this. And in my if you want, national healthcare activities, societal expectations for certain people are very different to what our norms are. And relatives often tell me, look, doctor, we are not coming here for you to tell us that there is nothing you can do. We are here to be told that you are doing something. They don't necessarily pin you down on what they want you to do. And often they do well understand that there is limits and certain things can't be done, but they don't want to be told that there is nothing you can do. So I guess that the messaging of the information is probably the most important aspect of it. And ultimately, I guess you get to a common pathway. But understandably, sometimes that may take time. And in certain contexts, we haven't got the resources and the time for that to happen.
Can I make one quick? And I will say, I am baffled by how often where the entire team's having the conversation, and Dr. Washington, you got to go in there and set down the law. This is crazy. And I don't. And then 2 days later, which is no time at all in the course of a 60-year marriage, right? They're like, yeah, thank you, you're right. And so I find just walking with families often at their pace instead of ours, when you have that luxury, because the world's not on fire, is often many of these conflicts disappear.
Thank you. Just to follow up, a principle that I didn't mention, but is very central to care ethics, is non-abandonment. And I think that's absolutely critical. No matter what, no matter how, if treatment is not successful, families and patients want to know that they will not be abandoned. I think we've all come across, I certainly have with family members, whenever curative treatment doesn't work, the clinician hurries by the end of the bed. That's not who we are, that's not what we want. So I think that concept of non-abandonment, that families and patients need to know that you clinicians are with them for the duration, whether it's a movement into palliative care, that is going to be a smooth transition, but they will have you as their fellow journey person. So I think non-abandonment for me would be a very important concept in this. Thank you.
I don't know if there are other questions, but yeah. Yeah. No, it's good. Thank you. Yes.
Good afternoon, everyone. My name is Somaya. I'm a critical nurse, educated and work in California state. Half of my life grew up in the state and half of in the Middle East, so I can say I'm pretty much familiar with both cultures. So I have first of all, I want to thank this opportunity. It's great to hear from each one of you, great talk. And it's very grateful to hear about the values, ethics, and morality still and be grateful that these values has not been digitalized with AI yet. So thank you very much. I really enjoy everyone speak. So I want to share my background with you. When I graduated from nursing school and I started as a new grad nurse, I found out a huge gap between what we learn at the school and what is implemented at the hospital, at the bedside. Then when I become a critical care nurse, the first thing I heard from the manager, you cannot be perfect. Whatever you have in your hands, you have to live with it. So seeing all these gaps between what is the values, the ethics, the moral, and what is actually implemented at the bedside. So my question to you, to all of you, especially and Dr. Ann's talk earlier about resilience, moral resilience, how would you find a solution? I left the 2 top hospitals rated in California because my values were not along with their values. I did not treat the patient the way I wanted to treat my loved one because we were short-staffed, because I had to sedate the other patient more, increase the infusion rate more so the alarm would not sound because I was busy with the other patient and did not have enough staff. Half of the cardiac ICU was run by the travel nurses, which they did not care about. The principal, the holistic care about at the bedside level, just wanted to survive their shift. So what are your solutions? And I would love to hear, because what I mentioned is in the state, they told me the ethic level. Well, at the night, we just know our limitation. We just drink our glass of wine and we forget about everything that we cannot do. I cannot do that. I want to put my head on the pillows thinking whatever I did today for that patient is the same thing I would do for my parents. I would love to hear your stories. Thank you.
Thank you. I'll make a start and then invite other colleagues. Goodness, and yeah, very sorry to hear your story. And sadly, all too common. I mean, I'm not even sure I'm in a position to speak. I've just come from the UK, where they're now recruiting nurses to deliver corridor care. So we're not in great shape. However, this morning, you'll recall, I did talk about the different levels to respond to and to help sustain moral resilience of nurses. So there's the individual issues. Now, I certainly don't want to pin any blame on individuals, but leadership and role modelling are absolutely critical. And again, I give an example this morning from my lovely colleague from South Africa, Professor Coetzee. During the pandemic, whenever people were struggling, I can hardly, you were there, but sometimes saying to yourself and colleagues, we are doing the best we can with what we have. That is a really critical point. And also just keeping our eye on the purpose. Why are we here? We're here to serve patients, families, and communities. It's not easy, but again, that concept of non-abandonment, we will do our best to stick with it. It is sometimes the case that nurses and other professionals work in cultures which are toxic and then they must leave. But I think we as leaders have a really important role in reminding each other and ourselves of our purpose and being creative. And we can be, and again, we saw it during COVID, but we continue to see it every day. But not stop there. It's not just about individual nurses, it's about organisations and calling out our organisations if their mission and their values are not directed towards the good of the patient. And then sometimes we need to get political. Again, we heard from a colleague in Ireland today about nurses going on strike. Yes, about conditions, but sometimes we have to get political, use our nursing organisations. If care is not satisfactory, then we do need to lobby. So I think it's at all levels, but I do hear, and you know, moral distress, I said this morning, I get so many articles every week to the journal Nursing Ethics on moral distress from around the world. It's not always a bad thing because it often tells us what is not right. When it's too much, good people leave the profession, and that is not what we want. So leadership, organisational leaders, and also political will is very, very necessary. But thank you for sharing. I hope that was helpful. Thank you.
Anyone else would like to?
I could go on all year about this. I would say I want to make sure just to reinforce what you said about the principle of non-abandonment involves in a particular clinical context that we will continue to walk with our patients' journeys even if they disagree with us. That does not oblige you to stay in abusive relationships. And frankly, we have seen repeatedly over the last 5 years in the American context, like just abusive relationships with nurses, and with the whole cycle of guilt and occasional rewards, and then more abuse and then guilt and occasional rewards. Sometimes you gotta walk. I will just briefly refer you to Dina Costa, C-O-S-T-A, at Yale, has written quite a bit about the reframing those feelings as foundationally about institutional failures, not about individual failures, and the institutional options that there are for response.
Don't want to be offensive, but sometimes, and I try and make sure I don't put this wrongly, you may feel to be the odd one out, or we as leaders don't understand that there may be individuals who don't feel the same way we do. And you may think everything is fine and there is no problem within your institution or within your department, but that is just because you probably haven't got insight in what's actually going on. So I do think there is obviously a problem in the case you're describing, which is not necessarily related to yourself, but of leadership. I'm very cynical about values, but because, we recite them at every meeting we have, funnily enough, I think, it's quite important to sometimes reflect about those, and I don't recite all of them to you, but inclusion is one of them, integrity, empathy, and teamwork, and if we just sort of process that a little bit, I guess, that there should be a way of making people who feel in the way you do come within the fold, try and find solutions together. Even if, we are in a very stressful environment with resource limitations, which gladly in one place I do have, and the other one I don't. So it's quite interesting to see the difference. But it's not about you. I think it is about the leadership of the organization, probably.
Anyone else has any question, comment, remark? One last. Oh, yeah. So there is a gentleman there.
Mark Angle from Montreal. The elephant that stalks every ICU that I've worked in is the issue of inconsistency. Do you have a framework for dealing with the fact that the average ICU physician only takes a shift of 1 week?
Hi. Well, I will just say, I'm not sure which, I don't think we know each other, but nice to meet another Canadian here. I don't know which hospital you work in. We have this conversation all the time at our hospital at the Toronto...
I'm sorry, it's the Montreal Neurological.
Oh, Montreal Neurological, okay. We have this conversation all the time at the Toronto General. And I think there's the argument against this, against 1 week because of loss of continuity and loss of rapport, consistency, et cetera, just to your point. I think that we historically keep returning to the 1 week because people are very tired. And I think that's an overarching concern that for fatigue and that will compromise performance and some of the decision making, to be perfectly honest with you. There are colleagues of mine in our group who recently have started doing 2 weeks in a row, despite our culture being 1 week. And I will just say that I think you start to, with fatigue, this is just a comment, not an indictment of anyone I work with. This is why I don't work 2 weeks, is I think you tend to start to drop off the tasks that are more time-consuming and emotionally difficult. And that tends to be communication. because it takes a lot of emotional energy to have difficult discussions, and just a lot of energy in particular. And I think the more tired you get, the more conflict averse you become, and perhaps the less willing you may be to engage in that. So this is why we've stuck to a week, but it's an ongoing discussion for sure. I think getting back to, I love what Anne was just saying, and other colleagues, I think if you have a healthy culture and good leadership, obviously there are variations in practice, but hopefully a cohesive group is behaving in a cohesive way so that the messaging is generally consistent with understanding that we're individuals and there'll be some variation from week to week. But that's certainly why our group has continued to stick with the week, for good and for bad. I don't know if others want to talk about that. And we do. I don't know, different people have different models. We really, the week at our place is hard. I got to just be honest. I find it hard too. We're up a lot. A lot of people are very sick. But we're a transplant center, ECMO center, ARDS center. So we have high acuity patients all the time. But others, happy to have people comment on that. Jack?
I guess I would say inconsistency is either acceptable variation or unacceptable. I do think that there's an approach to discussion through this, right? Transplant and questions of transplant eligibility, questions of ECMO eligibility at high functioning groups are actually quite reproducible across different people, no matter how tired they are. At low functioning groups, right? You kind of wait till 10 o'clock to see who's on for ECMO because you kind of know that guy's going to put him on for ECMO, that they weren't going to put him on at 9, and that's signs of dysfunction. I think you can work through some of these things. At Michigan, my surgical colleagues always called themselves, whenever they would take over a consult, they would refer to that my partner as doing that. And that is somehow never a language that's caught on in any ICU group, but I find the idea of thinking of what we do as partnership, and that what that means in part is also adapting to who's going to be actually able to do that surgery and what would their preferences be, because you know them, so you can smooth that yourself.
Well, I clearly fall in a senescence group because I guess a week I couldn't do anymore. We're working a resident on-call pattern in one institution, which means by default you couldn't do a long stretch of work. So I presume I've shown a slide yesterday regarding a timetable, admittedly they're very select, small, circumscribed group of people who all work roughly towards the same goals, all trained within the same institution, and a way around it, obviously, and I think COVID clearly has also destroyed a lot of the presenteeism within the hospital. So a lot of work is going on Teams and online. Nevertheless, there are very frequent touch points and opportunities to get together, and one of those, for example, is a long stay patients meeting, which in both institutions, private as well as on the national side, we do hold on a weekly basis, which means for the long stay patients, the complex patients, there would always be a handover, a discussion within the group about best ways forward, and trying to, that's not saying, in a compulsory way you have to do all the same thing, but at least for people to get an idea of what the team feels is the most appropriate action really to take. I guess for the, short stay patients in and out, it doesn't really matter. And I don't think there is a great deal of data which would suggest that having more consistency is better than having very frequent turnover.
I will have the last question. We have age, we have frailty, and we have quality of life. In this part of the world, you will face some families whose mom or dad or grandma, grandpa in the ICU. And they will tell you, no matter what, the fact that my mom, my dad, my grandma, grandpa are alive, that's life. And we want them there as long as, forever.
Yeah.
How would you tackle that one?
Well, I would just say that I have the good fortune of living in Toronto. And I say this as a very proud Torontonian and proud Canadian. We're currently under attack by the US, but that's another discussion. And, Jack. But in all seriousness, because I work in a downtown Toronto, a downtown hospital in Toronto, and I'm sure my colleague encounters this in Montreal as well, we have a very, very multicultural case mix. And I think as a result of that, we try to educate ourselves and be extremely respectful of what differences there may be inherently in goals of care that are that are driven by cultural or religious views. So this isn't that uncommon in our ICU. So I do, I would say that our group, not just me, would continue communication, continue to message investment, non-abandonment for sure, and respect the opinion of the family and the stance of the family, but remain in contact to continue to educate what's happening so that the family can continue to discuss it. Not to pressure, to communicate respect, no pressure. I would always say, I'm not pressuring you to do anything, but I just want to educate you about what's going on. Or our staff is concerned about suffering. Your loved one is developing complex pressure injuries. Your loved one is having multiple episodes of line sepsis, ventilator-associated pneumonia, challenges of chronicity, from which they will not recover. I mean, I would use language like that, but really frame it in a respectful way that I'm not pressuring, but educating and concerned about comfort and dignity, preserving dignity. And really framing it within the goals and values of that particular group that patient belongs to.
All right, the phones are all down, so I can say this without being recorded. I will say that I think I agree with everything Margaret said. I will refer you to also Katie Halshield has a wonderful book, a paper in the Journal of Health and Social Behavior that talks about the badgering that sort of particularly our young trainees sometimes do, where like every 12-hour, are you sure we can't have another code meeting? But I will say, I think the question you framed me did not tell me that my patient, to whom I have the primary responsibility, values that status. Right? The question as asked actually suggested that despite evidence that the patient would not want to be suffering, the family thinks this is the best way to protect them. And when I do that, I tend to spend a lot of time helping the family understand that sometimes you protect through the provision of ICU care, and sometimes you protect from the provision of ICU care. And really grounding myself at the bedside, I'll hold those conversations, saying, describe to me why you think this is what mom would want. And giving them, you got to give them something else they can do for their loved one.
No, I don't know what to say. I mean, sometimes you end up in situations where patients are at a minimal level of consciousness, and I ask myself the very question you've just alluded to, which is there suffering from intensive care? But to all intents and purposes, sometimes I feel, well, patient's probably not in pain. Whatever I feel is right or wrong, but in fact the family, they know their father or mother probably much better than I do, and they may actually not be suffering, but I believe that they are suffering and are projecting my beliefs into. So ultimately, it is sometimes a resource question. And yes, you know, if I had a choice and a full unit, and I've got somebody who's 90 in a minimal conscious state and are struggling to admit a multi-trauma victim or post-transplant young patient, it is really, really difficult.
Okay, and I guess with this lovely 4 sessions that we had earlier, we will conclude our last session of this conference. I guess this is the last session of this track. I'm not sure about the other tracks, if they're still ongoing or no, they are done. So we are the last. Thank you very much for staying behind. Thank you everyone for your lovely session. Thank you. Hope to see you again in a year or two. I'm not sure when Pan Arab will come back to us.